morning. Can you hear me? Yes, it's okay. I'm a bit of a sore throat as well today. So we're going to look at the last bit of the lower cranial nerves today, and then we are going to conclude with a brief look at the brainstem syndrome. So we are going to get all the all the lectures that we've had so far. We're going to get it to a logical conclusion by looking at the clinical syndromes here. So we'll look at the last two cranial nerves quickly, and then we'll go on to the brainstem syndromes. So the 11th cranial nerve, it's called the accessory nerve, and generally it's considered to have two components. The spinal component, which arises from the C2 to C6 cervical segments, and that's accompanied by a motor rootlet from the vagus nerve. But recent research also shows that the cranial component may or may not be present in most people. So it's the spinal component which is most important. Now, this particular nerve supplies only two muscles. The sternocleidomastoid, which is a muscle going from the mastoid right all the way to your sternum and the clavicle, and the trapezius, which is a large fan-shaped muscle at the back. Now, can anyone tell me why is this considered a cranial nerve? It's arising from the cervical segments, and it's innervating skeletal muscle. It's got no special functions apart from that. So why do we consider it as part of the cranial nerves? It's not arising from the brainstem. It's from the cervical segments. Sorry? Yes, so that's important. So what it does, if you look at the course of the nerve, it arises from the cervical segments here, and then ascends up the foramen magnum, and then descends down the jugular foramen with the 9th and 10th cranial nerves. So it's usually associated with a lot of the clinical syndromes that we see, and therefore it's considered as part of the cranial nerve. But it's a very simple cranial nerve. It innervates only two muscles. And this is how a person who has 11th cranial nerve palsy, his back would look. So the muscles kind of flatten out because of the trapezius there. Yes, and on movement, there can be a little bit of winging of the scapula, which is more characteristic with the serratus anterior, but you can get that a little bit with the trapezius as well. So the two muscles, when you have the sternocleidomastoid, the function of the sternocleidomastoid is unilateral contraction, rotates the head, and then bilateral contraction kind of flexes the neck. So we check that by asking the patient to rotate his head against resistance and knowing if there's a weakness on either side. The trapezius muscle is tested against resistance by asking the patient to shrug his shoulders. So it's a simple cranial nerve. There's not too much to discuss with this one. We'll go on to the hypoglossal nerve, which is the last of the cranial nerves. Now, this one is an interesting nerve because of the clinical implications. Again, very rarely is it affected in isolation. It's usually involved in syndromes which also involve the other lower cranial nerves. So if you look at where it's located, it's close to the midline, and the nerve travels out. The nucleus is close to the midline. The nerve fibers travel out anteriorly, ventrally, in between the pyramid and the olive. So it comes out there, and it has its own canal, the hypoglossal canal, which is right here, and it's very close to the jugular foramen. So a lot of the jugular foramen tumors or other syndromes here can affect the hypoglossal nerve, although it's not passing through the jugular foramen. Now, what's important about this nerve is that it comes down, once it's out of the hypoglossal canal, it comes out there and then travels very close to the internal carotid artery and the internal jugular vein, and goes below the tongue and supplies all the muscles of the tongue. And from the muscles of the tongue, the most important one to remember is the genioglossus. The genioglossus is genio because it originates from the mandible, right there in the center, and it's the main bulk of the tongue, and it innervates, it ends in the tongue posteriorly, and it forms the main bulk of the tongue muscle, the genioglossus. And that is the clinically most significant muscle when you are testing for the hypoglossal nerve. So these are the other muscles. The palatoglossal is supplied by the 10th vagus nerve, but all the other muscles are supplied by the hypoglossal nerve. And of course, you know the functions when speaking, tongue movements, swallowing, and things like that. It controls all that. Now, what's very interesting and important to understand is how the hypoglossal nerve palsy presents clinically. So when you're testing for a hypoglossal nerve palsy, you have to understand this. I've put this diagram in a little bit of detail. So you know that the motor areas arise for the hypoglossal nerve, the supracortical control or supranuclear control arises in the precentral gyrus from the motor area, right? Now, most of the tongue muscles are innervated bilaterally. The innervation for the genioglossus is mostly contralateral. So you don't have ipsilateral control. But all the other muscles, this is how the hypoglossal nucleus is, has the innervation. So the area of the hypoglossal nucleus which controls the genioglossus muscle, that has predominant contralateral control. No ipsilateral control for that. Now that's very important to understand and see what happens when you have a palsy. So for example, we'll take an example like the right sided control of the precentral gyrus. It controls the left hypoglossal genioglossal muscle here, and the left genioglossal muscle will innervate the left-sided, the nucleus will innervate the left-sided genioglossal muscle. Now, the action of this muscle is when it acts unilaterally, when you are looking at one-sided action, it deviates the tongue to the opposite side. So that means the left genioglossal would push the tongue to the right if it's acting unilaterally, one muscle. But if both the muscles act, it protrudes the tongue out in the midline. Okay? So if you consider the right side, if there's a lesion on the right side, in the a supra-UMN lesion, that's going to affect the left side supracortical control of the genioglossal muscle, supranuclear control, sorry, and that affects the hypoglossal nerve and the genioglossal muscle on the left, which is supposed to protrude the tongue to the right. So there's palsy of that, so the tongue automatically protrudes to the left because of the contralateral genioglossal muscle. Yeah. Okay? It sounds a little confusing, but it's very easy if you follow this sequence. So therefore, UMN lesion, the tongue deviates to the opposite side of the lesion. So you have a lesion on the right, and the tongue deviates to the left. In a LMN lesion, that's much simpler. If you have a lesion here on the right side, the right hypoglossal nerve innervates the right genioglossal, which normally pushes the tongue out to the left side. But with the palsy, the contralateral genioglossal is working, and it protrudes the tongue out to the ipsilateral side. So in an LMN lesion, okay, the tongue deviates to the same side as the lesion. In the UMN, it deviates to the opposite side. Okay? Any questions on this?
You said when you flex the genioglossus muscle,
Yes.
it's going to move in the opposite direction.
That's right.
The nucleus is stimulated.
That's right.
So in an element region,
Then it goes to the same side because of the opposite genioglossal which is acting. Yeah.
Is there a way to clinically tell whether it's an upper and lower?
Yes, there are other hints to that. So you go with the basic differentiation between upper motor neuron and lower motor neuron. So when you talk about spasticity or increased tone, that's more difficult to tell with the tongue. But you can definitely see signs like atrophy, which is a sign of a lower motor neuron involvement. You can see fasciculations. So when they protrude the tongue out, you can see little, I should have put a video of that. It's very interesting to see. I've seen that in a couple of patients. You can see very fine tremors in the tongue, and you will see atrophy. The atrophy is quite obvious. And by looking at that, you know it's an element. In a UMN, you will not get those signs, right?
Typically, when the lower motor neuron hypoglossal paralysis, he said that the tongue starts showing involuntary movements. People describe it like a bag of worms.
Yes.
Fasciculation, lower motor neuron, right? Fasciculation.
And this is basically how you test it. So you can see this. So the simplest thing is to ask them to protrude the tongue out, and you can see this atrophy on this side of the tongue. Yeah. And the other way to test for this is to, sometimes you can have a little bit of weakness, it's not too much, and you want to check if there's a mild hypoglossal palsy or a partial hypoglossal palsy. So to do that, you want to check how strong the tongue muscles are. And the way you do that is to ask the patient to push his tongue out against his cheek, and then you press from the outside and see how strong that feels and compare it with the opposite side. So that's one way to test that. So we move on to the brainstem symptoms. Now, remember when we were talking about in the introductory class on the brainstem, I said one of the reasons to really love the brainstem is because of its grid-like arrangement of the fibers. So you have the longitudinal long tracts which are arranged along the longitudinal axis of the brainstem, and the cranial nerve nuclei, and most of the cranial nerves are more horizontally oriented. So you have this kind of a grid. And if you understand what lies in which section of the brainstem, you can very easily localize the lesion. Yeah? So that's a basic concept we need to understand when we're studying brainstem syndromes. So the localization depends on the long tract signs and which cranial nerves are involved. And you can then very easily localize it. A few concepts before we see the actual syndromes is that there are three basic arteries. You know this already. We'll just run over it briefly. So the vertebral arteries run along the side of the medulla, and in the midline come together to form the basilar artery, which runs up the pons, which terminates with the posterior cerebral artery, and before termination it gives off the superior cerebellar artery. Now remember, I mentioned this earlier when we're talking about the brain, the cerebral hemispheres, we're talking in terms of anterior, middle, and posterior, because that's how the brain's oriented in a horizontal direction, but the brainstem is more vertical. So we are talking about superior and inferior cerebellar arteries. So the superior cerebellar artery is considered the artery of the midbrain because of its close relation to that. And these are all the relations to it. So we won't go into the details of that, but the midbrain is more closely related to the superior cerebellar artery, the pons to the anterior inferior cerebellar artery, the medulla to the posterior inferior cerebellar artery. That is not to say that these are the only arteries which supply these areas. There's a lot of overlap, and I'll show you a little bit of that right here now. This is an interesting diagram because you can see that the posterior circulation also supplies a part of the supratentorial brain or the cerebral hemispheres. Okay? Now that is the posterior cerebral artery. But the posterior cerebral artery does not only do that, it also supplies a part of the midbrain, a little bit. And there's an overlap with that. And then you have the second one, which is a superior cerebellar artery. The basilar artery is the third one, which is predominantly supplying the pons. And then you have the vertebral and the pica, or posterior inferior, which supplies the medulla. Now, a couple of things to understand in this. Usually the way the brain circulation functions, and this you won't be tested on something like this, but it's an interesting concept to understand, is whenever you have more than one artery supplying one territory, okay, so there is a reciprocal supply. So if one artery is predominant, the other one supplies less. And when the other one's more predominant, this one goes down. So same thing happens in the brain, in the cerebral hemispheres. When you have the MCA, which is predominantly supplying, the ACA supply comes a little down, and the PCA comes down. But if the PCA is dominant, then it can overtake a little bit of the MCA. So the watershed areas, what you typically learn, can shift a little based on which artery is dominant. Now, at your level, you don't need to know that from the syndromes, from the point of view of the syndromes and the clinical stuff, but it's an important concept to understand. Yeah? So there will be an overlap of these syndromes. Now, this is an important thing to look at. So this is a section of the midbrain, the pons, and the medulla. and how the arterial supply works in these three levels. You know that the basilar artery is in the midline, and here you have the vertebral artery. So we'll start with the medulla. Let's go with the vertebral arteries first. And in the midline, you have a branch from the vertebral arteries which join together to form the anterior spinal artery. Now that sometimes supplies a part of the anterior medulla, but mostly the spinal cord. Yes? And you have these long penetrating arteries arising in the midline or very close to the midline. These are called the paramedian branches. That's important to know because these paramedian branches, they go in to quite a depth and supply the brainstem in the transverse plane. And what can happen in the brainstem, and remember, all the clinical syndromes you're going to look at have been initially described with vascular insults, specifically ischemic insults or infarcts. Now, the infarct need not only occlude a large artery like the basilar, and a small embolus could go and lodge in one of the paramedian branches, and so you can get an infarct of just this region. And that's why it's important to know how these arteries are distributed, because the paramedian arteries supply structures which are close to the midline at all the levels, okay? And then you have branches which go around, which are called the circumferential branches, which go dorsolaterally, so it can be called the dorsolateral branches, which penetrate into the brainstem, and they supply. So you have different penetrating or branches laterally and different ones medially. So based on which branch of the artery is blocked, you can get a different clinical syndrome, because you know from the brainstem anatomy that the medial structures are different from the lateral structures. And if you just concentrate on this, you should be good with all the brainstem syndromes. You don't need to go into the details of every syndrome, or you know all the various classifications, because it's quite complex if you go into the nitty-gritties of it. But you don't need to know so much.
What is medial, what is lateral?
Yeah.
Medial is predominantly motor,
Lateral, sensory, yes.
remember that.
And then you get the visceral branches and all, which are also lateral. So now, before we start looking at some of the brainstem syndromes, it's important to understand that this term is used more loosely, and it basically is a term which applies to two kinds of syndromes. What's intramedullary and extramedullary. Now the word medulla here is not the medulla oblongata. It's the medulla, meaning the structure of the brainstem, within the brainstem or without, or on the outside, right? That's what the word medulla here means. It's not medulla oblongata. So intramedullary would be syndromes which occur due to an insult within the brainstem, okay? And extramedullary would be an external compression of the brainstem. So if you look at the syndromes within the brainstem, so this occurs with, this would involve long tract signs and cranial nerve nuclei. There's an early involvement of both. So if you have a stroke, you'll have the cranial nerve nuclei and the long tract signs being involved immediately. But if you have a tumor, for example, which is compressing on the brainstem from the outside, which would be in the category of extramedullary syndromes. Now, it would involve the cranial nerves initially, but to get the long tract signs, it has to cause that much compression on the brainstem. So the long tract signs come in later, usually. These are predominantly vascular insults to the brainstem, usually strokes, which could be ischemic or could be hemorrhagic. In ischemic strokes, because there's a particular branch which gets occluded, the clinical syndrome is very clearly defined. But if it's a hemorrhage, the hemorrhage does not understand those boundaries, and it can extend to other areas. So you can have a hemorrhage which has more vague syndromes. Usually the intramedullary syndromes, because of how they occur in the brainstem and the important structures there, we usually manage them conservatively, even if it's a big hemorrhage. You can't go in and get it out because you cause more damage, and usually the patients do very badly with that. But in the extramedullary syndromes, these are predominantly tumors, can be infections as well, and usually they would require some sort of a surgical management. So we got to go in and remove the tumor to alleviate the symptoms. Yeah? Now, just a general description on what to expect when you have ischemia of the vertebrobasilar territory. And I think this has been discussed before. Yeah, so it's this, I've stolen this slide from Dr. Ulal. So you're familiar with this, but can you volunteers on what signs and symptoms would you expect? So the entire posterior circulation is the vertebrobasilar system, right? We're not talking about the internal carotid artery, just the vertebrobasilar system. So in general, what kinds of clinical symptoms would you have? So vertigo and ataxia, these are very common symptoms. You have the important symptom of alternating sensory and motor deficits. We're going to look a little bit more into this because I think yesterday when I was talking about the facial nerve, a few of the students had this doubt about the alternating symptoms. Now when we will look at that in another slide. I'll come to the facial and this. But remember, if it's alternating, the face is involved on one side and the rest of the body on the other side, it has to be brainstem posterior circulation. Okay, you can have cranial nerve palsies, Horner's syndrome with ocular signs. How do you get hemianopia? Anybody? So the hemianopia is only, it's not a brainstem sign, it's only because of the posterior circulation, because the posterior cerebral artery, which also arises from the basilar, supplies the occipital lobes. So you can get visual acuity deficits and hemianopia and things like that in a posterior circulation, all right? Because the blood supply for that region comes from the basilar artery. And then the lower cranial nerve dysfunctions like dysphagia, dysphonia, and vomiting. Of course, altered consciousness is much more common because of the involvement of the brainstem and the reticular activating system than the supratentorial syndromes. Now, this is what I was talking about. This is a very simple concept actually, because the corticonuclear fiber, you have to understand that when yesterday when I was talking about the facial nerve palsy, the facial nerve palsies are not always associated with a hemiplegia or a hemiparesis, okay? But when they are associated, you can have a localized facial nerve palsy, and that will have no hemiplegia, hemiparesis. But when a facial palsy is associated with a hemiplegia or a palsy, if it's on the same side, then that would indicate a UMN lesion, because you're talking about the corticospinal tract involvement there. We're not talking about the facial nucleus, we're not talking about the nerve, okay? So all the fibers are on the same side. If you have an it's an alternating palsy. So you have facial nerve palsy on one side and a hemiparesis on the other side. Remember, the supranuclear control of the facial nerve has already crossed over at the nuclear level, and the motor fibers for the rest of the body cross over much lower. So when it's involved at that level, you will have contralateral hemiparesis and an ipsilateral facial palsy. So that should give you a hint it's in the brainstem. Are you clear on this? It's not a difficult concept. Any, yes?
So you said if it's an upper motor neuron
Yes.
lesion, it's going to be on the same side?
Yes. So that we're talking, when you say upper motor neuron, don't be confused by this. It's just the corticospinal tract or the pyramidal tract which is involved at some level. It could be the cortex, it could be the internal capsule, right? And all the fibers are traveling at the same time there. So you can get the involvement on the, everything's on the contralateral side, the face, arm, leg palsy, okay?
Same side, she's confused, I think. When you say same side, he's saying face and the body in the same side. Contralateral to the lesion.
Contralateral to the lesion, but the face, the alternating part is the face and the rest of the body. Those alternate. But if you have the facial palsy and the rest of the body palsy on the same side,
On the contralateral.
which is on the contralateral of the lesion, yes, so it's a pyramidal tract involvement. It's not, it has nothing to do with the facial nerve there, okay? Yes?
On the previous slide, you said ischemia of vertebrobasilar territory.
Yeah.
And you said hemianopia.
Anopia.
Yes.
Yeah. Yes.
I restrict brainstem.
That's why I stressed that point.
But if a patient, if ascending to posterior cerebral arteries,
Yes.
do I expect any ischemia in the vertebrovascular system to affect everything above it as well?
Not above it. It goes up to the level of the posterior cerebral artery. For example, I'll give you an example. I wanted to talk about this when I do the herniation syndromes a little later. But when you have a patient who has a massive hemorrhage or a really massive brain tumor and the patient's herniating, the herniation eventually affects the brainstem and the posterior circulation. Now, when we do a scan for these patients, we use one of the criteria as a bad prognostic criteria. One of the criteria would be an infarct in the posterior cerebral artery territory. That means that would be an indirect indication that the patient has already herniated, even if he's clinically not so bad, but it's a bad sign radiologically. So when they herniate, it affects the posterior cerebral artery, and you can get an infarct in the occipital lobes. And bilaterally, that's a very bad sign. So when you say vertebrobasilar system, remember occipital lobes are supplied by that. It's not just brainstem. But so when you say words like posterior circulation, vertebrobasilar, you can have involvement of the occipital lobes. Okay? Now, so we're going to do two things differently today. One, we're going to start from the medulla and come up to the midbrain. We haven't followed that scheme in the previous lectures. We were, yeah.
On your canvas, the order may be slightly different.
Yes.
I'm not talking about medulla, so please go to medulla. On the canvas, maybe showing midbrain.
Midbrain, yes. Yeah. So now, before we start on looking at some of these syndromes, can someone tell me what's different in this image as compared to what we have seen before? Yes. Sorry? It's radiological, yes. So for you guys, you have to be able to identify the section of the brainstem in both ways. So you can have ventrodorsal or dorsoventral, which one's up and which one's down. It may not be labeled on the test, on an exam. So you have to be able to identify important structures, and that's why I was stressing that when we were doing the sectional anatomy. So you have to know what's dorsal and what is ventral. Very important. And then what's right and what's left, because again, that may not be labeled. Yes? So what we are looking at today, all the images will be more radiological. Now, one of the reasons we see this discrepancy in the books and even the papers, journal articles, is because, remember, all the sectional anatomy was done and perfected much before we had CT scans and MRIs, maybe over 100 years ago. And therefore, that's the way they were studied, and that's an arbitrary way of looking at the slices, but that's how traditionally it's been looked at. Now, once we got the MRIs, you're looking at the image from below, and it's always ventral up and dorsal back down. So we have to change our understanding based on that. So you have to be familiar with both ways, anatomical and radiological, right? Now, we're going to look at the syndromes in a very simplified manner. We're going to look at it in terms of medial and lateral, because of the description that I told you earlier, the way the arteries supply blood to the brainstem. So this is a section of the medulla, and you can see the pyramids are there ventrally. Okay, so using terms like ventral dorsal is better than up and down or something like that, so you don't get confused. We have the 12th cranial nerve nuclei here, with the 12th nerve, hypoglossal nerve, exiting out between the pyramid and the olive. Okay, and you will have the medial lemniscus in this region. Now, if you have a medial, remember the penetrating arteries come in this way, okay, because that's ventral. Now, when you have a medial syndrome, it's this area which is shaded in pink, which would be involved. So you would have the pyramids, the 12th nucleus, and the medial lemniscus involved. And if you have a lateral syndrome, this would involve the other cranial nerves in the medulla. So you know what are the other cranial nerves of the medulla? The 10th and the glossopharyngeal. Okay, the vagus and the glossopharyngeal. Now those would get involved in the lateral syndrome here. Okay. Apart from that, you can have the sympathetic tracts, which would cause a Horner syndrome, and those are also located laterally. So have these concepts clear, what's medial and what's lateral. And once you know that, and you remember which artery is related to which part of the brainstem, I think you won't have any difficulty remembering this. There are lots of terminologies in this. There are lots of named syndromes, named after people who describe them, neurologists and clinicians. You don't need to know all the details of that. Yeah?
Lateral is spinothalamic tract.
Yes, lateral is spinothalamic. Yes, sorry, I missed that. So you have the spinothalamic tract. You can have the spinocerebellar tract, so you can have some ataxia because of involvement of these tracts without involvement of the cerebellum. And you would have the sympathetic ones we mentioned. You can also, in the upper part of the medulla, you can have vestibular involvement as well. Okay, so just knowing which structures are involved, you can know what kind of symptoms the patient would have. Please, please.
See, please do not forget there is something here. When you talk of
Yeah, sorry.
when you look at this, medial we generally say is motor, right? But please remember, along with the medial ligaments, and you got the 12th cranial nerve, you got the medial lemniscus, which is got the dorsal column fibers. So you have a person may have syndromes. I'm sure he's going to tell you that very soon. A person may have infarction on the medial side, medial territory, which leads to pyramidal tract involvement. You have 12th cranial nerve involvement and dorsal column sensations loss. Just because you see the word sensation loss, don't think of lateral. For lateral, it is spinothalamic. So
Yes.
pain and temperature dissociate them. Just like it dissociates in the spinal cord, it still dissociates in the medulla. Okay? Remember that dissociation. This is beautiful. If you don't get confused. Please, thank you.
So this is just to tabulate what we saw in the previous diagram. The paramedian branches would be the ones that would be affected in the medial medullary syndrome. Okay, and these are from the vertebral and the anterior spinal artery. So it depends on which part of the medulla you're talking about. If it's the superior medulla, it would be more of vertebral. If it's the inferior medulla, you can have the anterior spinal artery. Again, the structures of the pyramidal tract, and therefore you will get hemiparesis without involvement of the face, because we are the medulla now. The corticonuclear fibers have already left the corticospinal tract, right? The bulbar fibers have already left. So we do not get involvement of the face at this level. So like Dr. Ulal was mentioning, the dorsal column will have, you can have some ataxia because of that. And that's the sensory involvement in a medial syndrome. And you can get, because of the hypoglossal nerve, ipsilateral tongue weakness. And this is the lateral medullary syndrome. This one is named, you may remember this one name. It's called Wallenberg. It's named after the person who described it. This is probably the only name you'll come across. You need not know all the other named syndromes. And this arises from the circumferential branches of the vertebral, but also remember the pica, which supplies the medulla as well as part of the cerebellum. The structures involved laterally were the spinothalamic tract, so you would get contralateral involvement of pain and temperature. You would have ipsilateral Horner syndrome, which would have meiosis and hydrosis and ptosis. Vestibular nuclei, you could get nystagmus and vertigo. Spinal tract of the fifth, usually it's not such a predominant symptom in the medulla, but you could get that involved with facial pain and temperature. And then you can have the visceral symptoms of dysphonia, dysphagia, and taste because of the glossopharyngeal nerve involvement. Okay? Ataxia can also be there because of involvement of the inferior cerebellar peduncle. So this is all on the lateral side. Yeah? This is the pons. Now remember, again, it looks different from what we've seen before because the fourth ventricle is down here, okay, and the motor areas are here. So you have the pontine nuclei there, and you have the medial lemniscus again in the medial syndrome. So this would be the medial syndrome, and then this blue territory is the lateral syndrome. And there can be sometimes an overlap based on, like I told you, there can be an overlap of arterial territory, so you can have some overlap there. But in the medial syndrome, again, you can have the corticospinal and the corticobulbar tracts involvement. Remember that the sixth cranial nerve, which is a motor nerve. So if you remember from my first lecture, that the sixth, the third, sixth, and the 12th cranial nerves are located very close to the midline. So if you remember that, you'll also know at which level, which cranial nerve is being involved in the medial syndromes. So we have the fourth cranial nerve here, which is also very close to the, it's not shown in this one. You're seeing it. I'm so sorry. This is sixth cranial nerve. The abducens nerve, which would get involved in a medial syndrome. Okay, and laterally, again, we have a similar syndrome with the spinothalamic tract. So you would have contralateral sensory involvement. You would have the fifth and the eighth cranial nerves being involved here. So you can have trigeminal syndromes now, because we are in the pons, remember, and you can have a Horner syndrome on the lateral syndrome. And instead of the inferior cerebellar peduncle in the medulla, we've got the middle cerebellar peduncle. So you can have that presenting as ataxia as well. So this is the same thing, but just to show you what areas get involved here. And it's the other way that the pons has been put up, so you're more familiar with this way of looking at the pons. Yeah? Yes? Why isn't the facial? Yes. Here? Yeah. So if you have a syndrome which can involve the facial nerve here, but you have an overlap. So you can, depending on the syndrome, more often, because the facial nerve exits laterally, and the fascicular bundle, the intra-brainstem course of the facial nerve is more commonly involved in the syndromes. So the facial nerve is more commonly seen in the lateral syndromes. You can get an occasional involvement with the abducens nerve, yes, but we're talking about the nerves here. We're not talking about the facial colliculus. If that is involved, you would have a sixth and the seventh. Now we're not looking at all the possible combinations, but if you have an involvement of the facial colliculus, you can have the sixth and the seventh occurring on the same side. But most often it's after the internal genu. So once the facial nerve has gone around the abducens nerve nucleus and is going towards its lateral course, that's where it gets involved more commonly, and therefore you see the facial with the lateral syndromes, not the medial. That's a good question. Yeah. Yes, so in the medial pontine syndrome, you have the paramedian branches which are of the basilar artery. Remember, the basilar artery runs on the ventral surface of the pons, and so most of the paramedian branches in the pons would be from the basilar artery. And the medial syndrome would involve the pyramidal tract, so that would give you a contralateral hemiplegia, contralateral because the pyramidal decussation occurs in the medulla. We are higher than the medulla. So anything that occurs higher than the decussation, you get a contralateral. Okay. The medial lemniscus, again, you would have dorsal horn involvement, dorsal column involvement, and then the sixth cranial nerve. So this is a general outline for you to remember. So if you have pyramidal tract, dorsal column, and sixth cranial nerve, and you want to know which syndrome is it in the pons, you would say medial. So it's a general guideline, There are many syndromes which have overlaps and things like that. That gets more confusing. We are not touching on that today. So remember, sixth is generally medial. And yeah,
and
please.
One more thing, coming back to your question, seventh cranial nerve is a mixed nerve, right? So you expect it to be more lateral than the abducens. So in fact, if you go back to the diagram or the histology picture, you see that the lateral territory is where the nucleus of seventh cranial nerve is. It hooks around and then spends its time in the medial territory, then it again goes out in the lateral. So most of it is on the lateral.
So the nucleus is lateral, the nerve exits laterally, but it's just that loop that goes medially. And that's rarely involved in these syndromes. It could be involved, but rarely. This is the lateral pontine syndrome. Again, these are circumferential branches which would arise from the basilar, but in the lower pons also the anterior inferior cerebellar artery. Structures which are involved on the lateral side, spinothalamic tract, so you would get sensory disturbances on the contralateral side. Sympathetic, again, a Horner's on the ipsilateral side, so you get Horner's on one side and sensory loss on the other. You can get a fifth or a seventh cranial nerve involvement on the ipsilateral side. Okay, vertigo, nystagmus because of the vestibular nuclear involvement, and then ataxia because of the cerebellar peduncle. No, I think lateral conjugate gaze would typically go in a medial syndrome. Yes, not in the lateral. Is that right? I think because you have also the medial. Sixth is medial. Sixth and third are, yes, the MLF is also a medially placed structure. It's never lateral. The medial longitudinal that's why it's called medial, because it's more close to the midline. So you can get things like ataxia, nystagmus, and stuff like that. You will not get the vestibular nucleus connections with the MLF do not subserve conjugate gaze. They just subserve the reflex. Yes? Vestibular ocular reflex. If you move your head, and because of that it tries to stabilize the image on the retina. It just does that. But it doesn't affect the gaze. The gaze is affected by the sixth nerve and the medial longitudinal fasciculus. So that would all come in the medial. Now there can be other things. There can be internuclear ophthalmoplegia because of involvement of the medial longitudinal fasciculus. Usually those kind of details are not tested. So we're keeping it very simple here. There can be additional things, but the gaze is usually affected in the medial one, not in the lateral. And we cannot talk about the pontine syndromes without talking about a locked-in state. This is what Hollywood movies are made of, yes. There are lots of movies on this if you're interested. And it's very interesting because of the clinical manifestations. Now, a locked-in syndrome basically involves, it would involve, for example, a top of the basilar involvement where bilateral involvement of the branches of the pons is there. So you get an ischemic insult to both sides of the ventral pons. Okay, so the motor fibers are completely involved, and here you would also have impairment of the horizontal gaze. Okay, usually it can be there. So what's left is only the vertical gaze movements. Now, a person in this state would be perfectly conscious because the reticular system and the reticular activating system is more in the core of the brainstem, and that's usually not affected with the anterior syndromes. Okay, now, so the person is perfectly conscious, wide awake, completely quadriplegic. He cannot move at all. And he has very limited horizontal gaze, but the only thing he has is vertical gaze, and the blink movements are intact. So the way these people would communicate, it's very difficult to clinically diagnose a locked-in syndrome. I think I've seen just one case. It's rare, it's not very common. And it's difficult to know if a person is in a locked-in state or a chronic vegetative state, because it's unless they start communicating with you. And that can only happen by vertical eye movements or by blinking, things like that. And that's why they can make some wonderful Hollywood movies on that. But it's a very important syndrome to be aware of. Yeah. And you can have various pathologies. It need not be ischemia. Sometimes tumors can do that very rarely. If you have a diffuse pontine glioma, that can sometimes do that. So in which case it will not be a sudden onset, it will be a more gradual thing. The way you know a syndrome is happening because of the tumors or because of a vascular insult is because of the rapidity of the onset as well. A stroke, for example, and ischemia would happen within seconds to minutes, but a tumor compression or a tumor involvement of the brainstem would be over several weeks or months. Yeah, so we now look at the midbrain syndromes. And the midbrain syndrome is a little different from the other parts of the brainstem because you can have a medial syndrome, you can have a lateral syndrome, and then you have a dorsal syndrome. This is different in the midbrain. Now remember, I told you the midbrain is the only part of the brainstem which actually encloses a CSF space. The aqueduct passes through the midbrain and it does not pass through the pons or the medulla. It's posterior or dorsal to those structures. So here you have an additional syndrome called the dorsal syndrome. We'll start with the medial. So the medial one is located here. Remember, the third nerve nucleus is medially located, and the fibers pass out medially into the interpeduncular fossa, passing through the red nucleus here. Now, so if you have a medial syndrome, you have the corticospinal tract here. So you will obviously get involvement of the corticospinal tract. Depending on how much the ischemia extends posteriorly, you can get corticobulbar tract involvement, the third nerve involvement, and the medial lemniscus also. So this is not very accurately depicted here. It would be more closer to the red nucleus there, and you would get medial lemniscus involvement. Remember, medial lemniscus is involved in all the medial syndromes. In the lateral syndrome, you would have, again, spinothalamic tract, descending sympathetic, which is Horner's, and you can have red nucleus involvement. It is not a very important sign for you to remember, but red nucleus involvement can also give you some ataxias and things like that. Now, what happens in the dorsal syndrome? Now, dorsal syndrome on many occasions does not occur unilaterally. We see it bilaterally. Okay? It can be due to ischemias, hemorrhages, and things like that, but the commonest cause, and this is a little unusual from the rest of the brainstem syndromes, the dorsal syndrome, which is also called the Perinose syndrome, the D is silent because it's French, and occurs due to a tumor which arises from the tectum or the colliculi. So it's a very specific condition which you see these in. I'll show you a couple of examples in the next slides. Okay, let's just look at this quickly. So the medial midbrain syndrome, this is again named, you need not remember this. Paramedian and circumferential branches of the posterior cerebral artery. You can also have involvement of the basilar artery just where it bifurcates, and that's called the top of the basilar syndrome. Again, the pyramidal tract is involved. You get contralateral hemiplegia. You can get corticobulbar tract involvement. Now, the corticobulbar for the seventh is not involved here. So this was an error. So we've struck it out. I've struck it out. It's because we are in the midbrain, right? The facial nerve is not in the midbrain. And you can have third nerve involvement. So you can get an ipsilateral third nerve palsy in the medial syndromes. Lateral, again, would have circumferential branches of the posterior cerebral artery or the basilar. Spinothalamic tract, so contralateral pain and temperature. You can have an ipsilateral Horner's, and the red nucleus, which I mentioned, can cause ataxia. Now, the Perinose syndrome or the dorsal midbrain syndrome, you can get that again in the top of the basilar syndrome. Superior colliculus or the tectum of the midbrain is what basically gets involved in this. And we've discussed this, that it's the vertical gaze involvement that is predominantly affected in this condition. So I just wanted to show you this. These are MRI images of a patient with a tumor in the pineal gland. And the pineal gland tumor is compressing on and involving part of the tectum there. So you really can't see the midbrain very clearly. You can see the pons and you can see the medulla. Yeah? And you can see this is a axial section, and this is the third ventricle. So just behind the third ventricle is where the pineal gland is. And you can see this tumor, and this would typically cause a Perinose syndrome. And it's quite interesting that these people who, these patients who come in with this kind of a syndrome would be more symptomatic for the hydrocephalus that they come with rather than the upward gaze palsy. So upward gaze palsy, not something typically that a patient comes to you and complains of. He doesn't say, I can't look upwards. That's very unusual. Usually they come in and it's a sign. When you're examining the patient, you find out that the upward gaze is restricted. That's typically how they come in. And the same syndrome can happen with an ischemic insult in the same region here. So you can have, what I wanted to stress with this slide was that you can have different pathologies producing the same clinical syndrome. So by looking at a patient, you cannot know if this is a, it's an ischemia, it's a hemorrhage, or it's a tumor, except for some hints which you get clinically, depending on how long the symptoms have been present. Ah, okay. All right, I didn't see that. Thank you. So we have a few more things actually, but yeah.
So tomorrow we're going to complete this and then review some of the concepts. Okay. You can email us again once again. Let us know what
Yeah, so it's just about 5 or 10 minutes